Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. It's my pleasure today to welcome my co-host, as usual, Dr. Arjun Ghosh, consultant cardiologist at Bart's Health Center in London. Welcome, Arjun.
Thanks so much, Steve. Really looking forward to this episode.
And Dr. Dan Lenihan. Dan is at St. Francis Healthcare in Cape Girardeau, Missouri. Welcome, Dan.
Thanks, Steve and Arjun. As always, these are great sessions, and really looking forward to hearing what Tochi has to say for us. And it's always great to get her involved. And a few weeks ago, we did a recording about permissive toxicity that Charlie Porter did that podcast. And of course, Tochi was the main senior author on that paper. So please listen back to the previous podcast to learn about that concept.
That's great. And as Dan just mentioned, we're happy to welcome Dr. Tochi Okwuosa. She is a cardiologist and a professor of medicine at Rush University in Chicago. And today we're going to be talking a little bit about a growing area of interest across the board in healthcare, but as well in the cardio-oncology world, and that's the interconnected social determinants of health and disparities in cardiology care, cardio-oncology care. Before we jump into that topic, I wonder, Tochi, if you can just tell us first just a little bit of your background, kind of how you got interested in cardio-oncology, and then we'll jump in on social determinants of health.
Yeah, hi. Thanks for introducing me, Rick and Dan. It's a great thing to be on this podcast. I became interested in, as you already mentioned, I'm a cardiologist at Rush University Medical Center. I became interested in cardio-oncology when I was a junior faculty at Wayne State University. Basically, one of the attending physicians at a conference mentioned something about, a fellow presented something on anthracycline cardiotoxicity. And then one of the attending physicians at conference mentioned cardio-oncology and how it's an up-and-coming field in cardiology. At the time, it just happened to be that I was kind of trying to figure out where I fit in general cardiology. And so it became something that I wanted to learn about. I read upon it and got some more information about it, and actually seemed like a specialty that I was very much interested in. When I was a cardiology fellow, I did a lot of moonlighting at University of Chicago, which is where I trained for the hematology oncology department. And so I had a lot of background in hematology oncology already to speak of. And so combining that with cardiology seemed to be something that was quite interesting and something that I was excited about. So after learning more about it, went to MD Anderson conference and also shadowed some physicians in cardio-oncology clinics. I decided I was really excited about this specialty. And so I find myself in this specialty, and it's been a great road and a great journey so far to a patient population that's extremely complicated and extremely sick as well, that we have to take care of, and very, very rewarding taking care of this patient group of patients. And the oncologist are also extremely grateful to have a cardiologist that understands their medications, understands the intricacies of care for their patients, and knows how to manage them. As Dan mentioned, permissive cardiac toxicity, knows how to manage these patients while they're getting their cancer treatments and even to survivorship years without having to say, oh, it's time for you to stop chemotherapy, or it's time for you to stop whatever therapy they're getting for their cancer. So really exciting field. And I'm so excited to see how far it's come in the last few years. And I think that the sky is the limit for cardio-oncology in terms of growth. And also we're all increasing our awareness now, always in the different conferences as well.
Wonderful. That's super helpful to hear. And as you mentioned, cardio-oncology generally is a complicated interdisciplinary approach to healthcare. And then I think there's a growing awareness, as we said at the start, of just the social and economic influences on healthcare generally. And then you bring that into the cardio-oncology world, and it creates a whole nother layer of complexities we have to think about in caring for these patients. So Arjun, Dan, what are your thoughts and questions in this area of our work?
Thanks a lot, Steve. So I probably would just follow on from the point that you made that, cardio-oncology itself is a very complicated area, especially when you're originally, getting into it with the interplay between cardiology and oncology. And, one of the issues with the socio-economic issues in cardio-oncology is that it's a massive, massive field, but it's a very important area in health in general. And it's really nice to see that there've been a number of recent papers on the topic, just highlighting this really, area of cardio-oncology that we should be focusing upon. We know that it's racial issues, it's economic issues, it's even issues with gender that can have an influence. Black survivors of breast cancer have elevated risks of cardiotoxicity compared to white counterparts. Younger patients with lower socioeconomic status have worse outcomes compared to those of a higher socioeconomic status. And even, female patients of commonly used drugs like anthracyclines or radiation have higher cardiotoxicity compared to male patients. So lots and lots of different issues. So I think that, the aim of today's podcast is really not to be able to get into every, minutiae of all this, but just to hear from some thought leaders in the field on what they feel about, this massive area. So maybe I could just start off by asking a very general question, and that's, what is, the biggest determinant of these adverse outcomes, would you say?
So I would say that, based on what you've just said yourself, Arjun, I think social vulnerability, right? So if you think about it, when you talked about your examples, you mentioned a Black cancer survivor compared to whites, right? So socially vulnerable population. You mentioned socioeconomic status, again, socially vulnerable. You mentioned women versus men, again, socially vulnerable. So the way I look at it is I think that people that are socially vulnerable and may not necessarily have either the time or the resources or the wherewithal, however that comes, to be able to advocate for themselves or be able to see the right set of providers or even have access to the right set of providers or the right sort of institution for care are usually people that end up being disadvantaged when it comes to health outcomes overall. And I think that's the story overall within the United States and in fact, much of the world. And the cardio-oncology, nonetheless, we are seeing the same sort of disparities that we see in overall cardiovascular health in cardio-oncology. And I think again, that social vulnerability is a huge part of it. And because in the end, social vulnerability also links directly with resources. So if a given group are socially vulnerable, they usually would not have resources to be able to either care for themselves or resources to get the best sort of care.
Yeah, I think that's exactly right. You've hit the nail on the head. But there was an interesting point that you mentioned. You talked about the problems in general accessing, cardiovascular, health, accessing, medicine or medical help in general. Do you think, Tochi, that there's any special, socioeconomic issues for cardio-oncology patients compared to somebody just accessing health, medical help in general? Is there something different for the cardio-oncology patients? Is it double the trouble with two issues?
I mean, I know that there are some studies more recently even that have suggested that they may be double whammy, like as you mentioned, so to speak. You're going to think about disparities in cardiology specifically, and then you're also going to think about disparities in oncology as well. And then it's kind of sort of marrying the two. So some studies, more recent studies, are actually suggesting that it's possible that this is assessing disparities in healthcare with respect to cardio-oncology is relatively new. So we don't really have enough data to assess this. But the suggestion is that if you merge the two, the disparities are higher in the cardio-oncology population. Now, how that plays out is what we're all watching and we're all going to see. But it is possible that the typical disparities that we see in cardiovascular disease may be increased or maybe even multiplied to a certain extent, depending on the situation.
The Global Cardio-Oncology Summit is the leading yearly update in cardio-oncology. This year's meeting will be held in Madrid, Spain, gathering the top experts in research, science, and clinical care from around the world. The 4-day event begins on September 27th with a basic and translational research symposium. On September 28th and 29th, the main sessions will take place, and this fantastic event concludes with a half-day session focused on cardio-oncology nursing on September 30th. New this year is the ICOS Champions League competition, a friendly and fun quiz event centered around cardio-oncology knowledge and clinical cases. The Champions League competition is open to all healthcare professionals, so make plans to join in. For more information, visit icos.org, that's ic-os.org. We look forward to seeing you in Madrid this September. Treat cancer, protect hearts.
Okay, and do you think alongside the socioeconomic determinants, are there any other factors such as, medical factors, genetic factors, the way that, some ethnicities are more prone to, say, developing hypertension? Would that have an influence, do you think, with, say, VEGF inhibitor cardiotoxicity? Do you think that is a step too far, or do you really think that it's all about mainly the socioeconomic side of things for the vast majority of patients when there are these big disparities?
Arjun, I think that's a good question. I think it's easy to point to genetics when there's disparities in healthcare one way or the other and say, oh, this group has more hypertension. I mean, to your point, I think hypertension, we know, is a great risk factor. We talk about VEGF inhibitors. They cause really bad hypertension and significant, even malignant hypertension in patients. And patients who are exposed to anthracyclines are more, 3 to 5 times at risk for having cardiotoxicity and cardiomyopathy and heart failure if they have hypertension in the background. I understand that as a risk factor. However, blood pressures can be controlled regardless of race, regardless of genetics. And if that is the case, why should hypertension play a role in this sense, right? I can tell you that so far from the very, very little that we know, there is not, as far as we can tell, disparities in terms of VEGF inhibitors causing hypertension in one population versus the other. And if that's the case, then how can the genetics of hypertension play a role in creating disparities in this population, right? So if these, the argument I'm making is if these particular groups of patients are given are actually taking the antihypertensive therapy as they should, assuming a clinician got to them in time to start them on blood pressure medications, and the blood pressures are controlled, or assuming that the patients advocated for themselves or took it upon themselves to have their blood pressures measured and their blood pressures are controlled, then technically speaking, that there should not be any disparities. If blood pressures are controlled, there's less risk of cardiotoxicity and cardiomyopathy from anthracyclines. Their blood pressures should be controlled when patients are on VEGF inhibitors. Then if that's the case, then there shouldn't be much of any disparity when we're talking about outcomes, right? Maybe some level of disparity in terms of the number of blood pressure medications that may be required, but there should not be disparities in outcome, if that makes sense.
Yeah, no, that makes complete sense, and I agree with you. Once you kind of remove that side of, why shouldn't everyone be receiving the good treatment, same treatment, controlling the blood pressure? Then probably after that, no particular group of people is more prone to develop cardiotoxicity. So yeah, I completely agree. I think, and also I guess we're moving on to a different part of the topic now, talking about maybe what we can do to change things. So I think I'll hand over to my co-host, Dr. Lenihan, to ask some of these questions. But, really nice introduction, I think, just kind of laying the groundwork on how complex this whole area is.
Yeah, I think, this has been a great discussion. And I think what it usually does is just introduce many more questions to pursue or actions to take. So I do want to kind of at least provide some perspective on how I see it. Now, whether that applies to everybody else, I have no idea. But I think that if I think back to when I was an intern or a resident, and they were just starting the NRMI registry in the United States, and that stands for National Registry of Myocardial Infarction. And basically, when they started that registry, they were asking simple questions like, how long did it take for a patient to get from the home to the emergency room, with chest pain? And then how long after they presented to the emergency room did they get an EKG? And then, ultimately, how long did it take them to get to the cath lab or get thrombolytic therapy, et cetera? So these were the basic questions. They were just, what's happening in practice, basically, at the time. And, the initial data set was just 2 or 3 pages that you, on each patient, you just faxed them to a center and, they tabulated all this information. Well, so why am I going back to like 1990 to talk about this stuff? Because what was happening there was basically what has transformed the treatment of myocardial infarction in this country and probably many other countries. But because we were looking at how much time it took and, which hospitals were more responsive. So whether it was an academic center or a community center, or who had intervention on site, or whether they had to go to a different place, and all these sort of just practical details. And over time, that database got more and more complex. And then you look at now the current situation about treatment of myocardial infarction. We got helicopters flying people from smaller hospitals to bigger hospitals in the middle of the night to try to keep the time down. So, in terms of time from when the patient presents with symptoms and they get ultimate treatment. But you think about the whole system was created to normalize practice for the whole group, for all of the United States. And that whole process took 20 or 30 years. And if you go back to 1990 and say, this is what was happening then, and now current day, you say, oh, wow, look at all these systems in place that we have to get people to the right, intervention as quick as possible. Well, in cardio-oncology, I feel like we need to do the same thing. Maybe not quite as grand a scale, but, right now, like Tochi, you have spent a lot of time in Chicago, and that's, one of our busiest, was the 4th largest city in the United States, or maybe 3rd, I'm not sure, but nonetheless, a massive city.
Third.
Okay,
Yes.
3rd. Sorry, I didn't mean to slight Chicago in any way. But, anyway, we have this massive city, but, if you thought about it, how much influence does cardio-oncology have on the practice of treating cancer in Chicago? How big of an influence do you have? And if that influence is, let's say, small right at this moment, how can you make it bigger? So you can't just stay connected only to the academic centers. You have to get out into the community and make sure that, the best care from Dr. Okwuosa is delivered in the majority of places. It's not just only in one major center. So how do we apply, good basic cardio-oncology principles to many different locations, many types of institutions or practices? And to me, that is how you're going to address disparities. If you only focus on how you manage a specific institution, the influence on the whole community is not big enough. At least that's my opinion. So I don't know.
Then I couldn't agree with you more. Actually, he hasn't asked me any question about how to manage, because if he did, this would have come up. Although I have to say, I learned a lot of history about acute MI just listening to you tell us about the registry and how it was built and all that. So this is great.
Well, yeah, I mean, that's what happens when you're old.
But this is the sort of thing that I am pushing for in cardio-onc. One is education, right? So I'm not just talking about educating our fellows, which is extremely important, educating the oncology and their fellows as well, which is very important. Our colleagues, right? As you know, we have this Chicago citywide cardio-oncology rounds. We just published a paper in JACC last month about this. I think that is the reason why we actually formed that group. It's a cohesive group, and the general focus is educating each other, learning from each other, being collaborative in the work that we do. It's a huge city. Once I went, to give a grand rounds talk somewhere, and the chief of cardiology at that institution asked me, "Oh, you guys are all institutions that are, sometimes half a mile apart and actually sometimes right next to each other. Aren't you guys fighting for patients?" And the answer is no. There's enough patients to go around in cardio-onc. There's so much more to be gained by all of us being collaborative and being cohesive, as opposed to each of us fighting for patients, honestly. And we have, as you mentioned, it's the third largest city in the country. So we have a good number of patients. That's not the question. And as we're educating each other, spreading out that education, right? As you mentioned, Dan, you have a patient that comes to our, tertiary centers to get treatment. After they get treatment for their oncology care, most of them leave the tertiary center because usually the tertiary centers are far away from them. Sometimes 2 hours, sometimes even people have to make 4-hour drives. Some people coming from out of state to get treatment. So most of them go back to their local physicians. Well, what happens? People forget, the local physician over the years, nobody thinks about the fact the patients, if the patients are not aware and are not advocating for themselves, people eventually forget that they received an anthracycline, or they received chest radiation, or they received pelvic radiation. And that sometimes when these patients are coming with symptoms, that some of their symptoms may be tied into these treatments they're receiving. And going on to more recent times, a lot of patients as cancer survivors are receiving medications, pure cancer medications, that people don't even think about. People don't think about the fact that this particular drug that they're receiving could be a cause of certain types of complications in them, because they're pills. They're not getting IV meds. It's not a quote unquote infusion. And so because of this, people forget. And then it's very easy for people to forget certain symptoms that they may have and think about cardiotoxicity as possible cause of those symptoms. So educating these local physicians that are taking care of these patients is particularly important. So that's one. And again, forming forums or conferences or symposia that can inform these physicians is particularly important. So that's one. Then the other aspect of all this is database building. I think that we have a long way to go in building databases in cardio-onc. You mentioned the acute MI registry. Something like that in cardio-onc is particularly important. If you think about it, in cardio-onc, you have different types of cancers, different types of treatments, different types of combinations of treatments, different cardiovascular risk factors, different cancer factors, different everything for a lot of these patients. There is not a single cardio-onc patient that's exactly the same as the next cardio-onc patient. This is part of the reason why we talk about how complicated this patient population is, right? A patient comes into a general cardiology clinic, they're having chest pain. You don't really, the workup is basically set, and what you're going to do for that patient is set. A cardio-onc patient comes to a cardio-oncology clinic and they're having chest pain. What you have to think about for that particular chest pain that this patient is having is different. It's going to be different for each patient, depending on these factors that I mentioned, relating to cancer therapy. That's going to be different in a certain way for that particular patient. And so building a cardio-onc registry, so the point being that if we decided to get into clinical trials in cardio-oncology, we may never, and most likely would never really understand cardio-onc as much as we should, right? Because each clinical trial is going to be looking at a subset of the patient population. However, if we had some sort of database registry, particularly a national database registry, then it's easier for us to be able to basically tune up or identify those little nuances that are different for each of the patient population, and then be able to answer some of the questions that we have to answer in this population. And that ties into disparities in a very big way, because some of the most important set of data that we're going to be gathering, if we decided to do a database registry, would be on demographics, in every form of demographics. And this would be particularly useful in assessing disparities in care in cardio-oncology.
Yeah, that's a great point that you raise, Tochi, in terms of having the databases and having that big data to drive the conversation. Do you also think that we also need the clinical trials to be designed in such a way that this type of information is properly captured, which can then feed on into the databases? Because I think that a lot of our ignorance is due to the fact that we don't have the data, we don't have the evidence to go to our policymakers and say, this is something that we need to target. I mean, I don't know whether you have any thoughts on that.
Yeah, I mean, I think clinical trials are particularly important, as I said, in terms of studying cardio-onc. But again, if you think about the combinations and permutations of different aspects of each cardio-oncology patient, it'll take hundreds and hundreds and hundreds of clinical, not thousands of clinical trials to be able to answer each nuanced type of question in cardio-oncology. And so I think that clinical trials are particularly important because it's good to get very objective data from clinical trials. But I think building a database registry is a good way to push the field forward faster in such a way that we have basic understanding of some of this. A good example for this is when I'm talking about databases. A good example is this was immune checkpoint inhibitors came into being, right? And when they came in, nobody really thought about myocarditis as a side effect of immune checkpoint inhibitors. But, through the years, there were case reports on immune checkpoint inhibitors and myocarditis. And then Javid and his group published this information from a database, from VG-based database on immune checkpoint inhibitor myocarditis. And suddenly, the entire cardio community and hopefully cardiology and oncology community are now aware of this particular side effect of immune checkpoint inhibitors. So this is an example, right? Is if we decided to focus on just clinical trials, I don't think that we're going to get to answer many. I mean, I'm sure Arjun, you're in this with me, multiple questions in cardio-onc that we have to answer. And so I think a database registry, again, a national or more global type of database registry is probably the way to go in answering the number. Because then the thing about it is it's very easy to study all the subsets of patient population that we want to. And then again, it's easier to build demographics data that we can then study and then use some of the signals from the database registry to then set up appropriate clinical trials to answer some of the questions that we have to a finer point, to a final level, if that makes sense.
Yeah, no, that makes complete sense. I think, Dan, you have some thoughts as well.
Yeah, no, this has been an important conversation for sure. I think that, one of and what you described about organizing a Chicago-wide sort of conference is a fantastic step. And that is like super good. And, we need to duplicate those sort of efforts in many places. And that's, one way to kind of get the message out. But again, if you go back to and I certainly am a big proponent of databases, the problem is getting some funding or mechanism to collect the data accurately. That's like the biggest challenge. But I do think that, the message should be, if there are some sort of disparity in how patients are treated and whether or not they have a higher rate of adverse events, the best thing that we can do in the end is to make cardio-oncology available to the broadest population possible. So how we integrate with smaller communities and community-based practices is the essential piece there. I think we have great major institutions that are really committed to these things, but their reach is only so much. They can't go beyond that. And so that's really how do we get it out into the community to make it so that cardio-oncology is an essential piece of patients' cancer care. That's really the bottom line, and as I see it anyway.
Yeah, I think I couldn't agree more. Educating the community around this. I also think, to your point, Dan, one way to do this is also to start the cardio-onc education in medical school. right? Because if you start from the ground, you're able to work your way up, right? That's the way I look at it. So if we start with the students and the students think about it and it becomes a part of their education, they take it into residency, take it into fellowship, and as attending physicians, it becomes a part of their practice. In my opinion, that's the one way to disseminate it far and wide. So if there's a way to incorporate, I think most medical schools teach about anthracyclines and trastuzumab or anti-HER2 therapy, but I think really incorporating cardio-oncology as a topic under cardiology, I think that would be one way to move forward with what you're thinking, Jen.
Yeah, I think, getting at the beginning is always a key piece, but I would also say, whenever you're addressing a major task, so there is a big task in front of you, whatever it is, you can try to develop one strategy that's going to solve all the issues, but usually what works better is come up with multiple explanations or multiple plans to address it. So you're going to address this part by, teaching medical students, and that's fantastic. But you're going to address the other part by, those practitioners that have done their fellowship many years ago, but they sort of seem interested in what's going on. How do you get that message out to them in the middle of their practice, in the middle of their day? That's a real challenge. And, they already went to medical school. We can't catch them in it.
Make it a part of the cardiology boards. and your continuing education and part of the ABIM, long-term knowledge assessment and the rest of them. I think if there's a way to also incorporate it, I think that's one way to also open everyone's eyes. Again, I've talked about conferences, I've talked about research. So I agree with you, a multi-pronged approach. I think we have to kind of think about it in a multidisciplinary, number one, and also in a holistic way. I agree with you that you have to be multi-targeted in doing that. And I think making sure that while we're doing that, kind of back to the basic topic that we're discussing, that while we're doing that especially when we're thinking about research and when we're thinking about education, that involving including socio-economics and socio-economic determinants of health, and including the sort of disparities that whatever is being published in the literature and including that in our thought processes that we're thinking about it is one of the ways that we can at least focus on trying to reduce disparities in cardio-oncology care.
Super. Yeah, this has been really great. How do you see your Chicago-wide group? How do you see that developing over time?
I think right now the main thing that we focused on is on the conferences where we get together and educate each other. So kind of talking about education and starting from ground, working our way up, that sort of thing. We when we're doing the Chicago rounds, we usually have a resident or fellow present. And actually, out of the residents and fellows that have presented, we have at least 3 or more of them that are now interested in cardio-onc. And actually, one of them just got a faculty position in cardio-oncology at Cleveland Clinic. Her first foray into cardio-oncology was presenting at our Chicago Citywide Cardio-Oncology Conference as a resident 3-4 years ago. So that kind of gives you a sense of where we are. The other one is going to be applying for cardio-onc next year. And then there's another one that's coming up. So kind of getting these residents and fellows involved is part of how we're training the next generation of cardio-oncology specialists. So education is one. Then for the education, we're also educating each other in our academic centers, but we are taking some of what we're doing to the community. So we make some of our cardio-onc rounds virtual, and we announced it with the Illinois ACC, or Illinois American College of Cardiology. That's announced regionally within the Illinois, Wisconsin area, so that even the local physicians or local cardiologists that are not that are not cardio-oncologists or that do not belong to academic centers that are working in the community can get the message to attend these conferences. So that's also another way that we're doing the outreach. And then part of the collaborative efforts also is thinking about research for the future. So we do have some things in works that we're having conversation about some of our colleagues to build, a sort of maybe a Chicago-wide or regional sort of database in cardio-oncology. So there's a few things that we're working on. There's a few things that we're thinking about, and looking forward to the future. I think the focus is going to be on education, collaboration, and research.
Super. Wow, that's really fantastic. And I love hearing about that. That is just, that's an example that we all need to follow. So thank you so much for that.
That actually fits perfectly with our mission statement as an organization: training, education, and research. That's what we're all about. Well, this has been a fantastic discussion. Tochi, we really appreciate you taking the time and sharing your insights. And I know this is going to stimulate a lot more conversation and hopefully some new research, training, and education in our community. So thank you so much for joining us today.
Thank you for having me. Thank you, everyone.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.